Let's talk about Achilles tendon ruptures today. As we've seen earlier, Achilles tendon is a tendon that is a continuation of the gastrosoleal muscle complex, which comes down and attaches to the heel bone at the back. Extremely important muscle and tendon for plantar flexion, which is bending the foot downwards like this. It's also very important in pushing off the toe, important in the athletic population. Typically, this is a man in his 30s or 40s who's suddenly taken up a new sport or overdoing a certain sport. He's playing it and he suddenly feels as if he's been stuck at the back of his heel and he's unable to continue play, especially he's not able to push off, it's weak, it's painful, and that's how they normally present to us. Mechanically, what happens is an extreme eccentric load on the tendon, especially when the foot is dorsiflexed as well as the knee is extended. When such a force goes through, that's when it ruptures. Usually there's a zone of what we call as a hypovascularity, decreased blood supply, roughly about 2 to 4 centimeters from the insertion site. Typically that's the site where the tendon ruptures. And of course, when they present to us, we do go into detail into history of the mechanism of injury, how it happened, and also we look specifically for any underlying conditions that might have predisposed to this rupture. For example, are they on any specific medications like steroids or a specific group of antibiotics called fluoroquinolones? Is there any malalignment of the feet or the knee joints, or if they are having any underlying hormonal or metabolic issues like gout, hyperthyroidism, sometimes chronic renal insufficiency. So we go to all these issues to see if there's any underlying problem that might have caused this to rupture. Clinically, they will have a site of tenderness at the point of rupture. Sometimes a gap is palpable. They'll have weakness for plantar flexion. There's a test called the Thompson's test, or the calf squeeze test. Normally when we squeeze the calf, the foot goes into plantar flexion. That may be absent, and they will be unable to stand up on tiptoes, especially on the affected foot. So these are the clinical symptoms and signs that give us a clue with regards to tendon rupture. Sometimes in addition to these, we may have to do an X-ray. An X-ray will show us if a part of the bone has been pulled off, what we call as an avulsion fracture. In addition to that, we may ask for an ultrasound or an MRI sometimes. So the treatment of these acute Achilles tendon ruptures can be both non-operative or operative. The decision to whether we are going to operate or not depends on a variety of factors. One is, of course, the age of the patient, the level of activity that they're pursuing, and the type of sports they want to pursue, and of course their understanding of risks and complications. For there are pros and cons of either approach. For example, in non-operative management, of course, there is hardly any chance of any surgical complications. The re-rupture rates are quite high, whereas in the operative approach, the re-rupture rates are very low. Of course, there is a small chance of surgical complications. So the final decision is usually made after discussing with the patient their requirements and their understanding of the risks and complications. But in general, we tend to favor surgical approach in young athletic population as opposed to older gentlemen or ladies who are not so active and who have a lot of comorbidities. In these groups, we tend to favor a non-surgical approach. The standard non-operative treatment consists of putting the foot in equinus, which is plantar flexion completely, so that the two ends of the ruptured tendon come together, and the whole foot is immobilized in a cast for about 6 weeks, giving it adequate time to heal, and then afterwards slowly bringing it to neutral, and then removing the cast in about 8 to 9 weeks, and rehabilitating after. But of course, there are accelerated protocols where we are able to do this much earlier too. Whereas the surgical treatment consists of course, making an incision at the back, close to the tendon, and going in there, looking at the tendon, freshening up the edges, bringing them together, repairing them with special tendon sutures, and again after surgery, immobilizing them for a shorter period in a cast, and gradually rehabilitating them. There's another group of patients that present late, usually after 4 to 6 weeks, either because they didn't seek early treatment or because it's been missed. These fall under the group of chronic Achilles tendon ruptures. When we operate on these, it may not be so easy because of all the fibrosis and contracture. The ends, it may be difficult to get the ends together. If such is the case, we'll employ additional measures. There's a technique called the VY lengthening, where we go proximally up, V incision, pull the tendon down, and resuture the resulting Y, and that helps in releasing the tension so that we can get the two ends together to repair. And then there's another procedure called the turn down procedure, where we take a strip of the fascia, turn it down, and provide additional support for the sutured area. If that is not enough, sometimes we harvest an additional tendon, usually the flexor hallucis longus tendon called the FHL, which usually helps in bending the big toe. We can harvest it right here, here, or here. We use that tendon to accentuate the repair. Achilles tendon ruptures can be quite disabling. They can be either treated non-operatively or operatively, depending on the type of patient and the requirements. Younger athletic patients who are treated surgically are able to get back to sport within 4 to 6 months.